So my name is Shi-Joon. I'm a radiologist. For a long time that I haven't done any imaging other than cardiac imaging, especially the pediatric cardiac imaging. So I'm pretty much this really too much specializing, and I don't have any place to go because that my specialty is so narrow. But here really I enjoy, especially that here for this course. I'm very honored because that HeartLink really made a great the arrangement for this meeting. I'm very honored to work on this really important program with Dr. David Barron and all our cardiac surgeons. I'm very proud of, and it is very valuable. So in the next 40 minutes, I will talk about the overview of the double aortic right ventricle. It's mostly the morphology. So what are the essential modifiers of double aortic right ventricle? So this is a priming question. The first question, double aortic right ventricle is a uniformly definable pathological entity. Do you agree or not? The second question, double aortic right ventricle is characterized by both outlets supported by muscular infundibulum. True or false? Just to have your own answer. And then third, this case has this is open the right side of the heart, right atrium, right ventricle, and aorta, and this is subpulmonary outflow tract obstruction, small pulmonary valve, and VSD is underneath the aortic valve. In the short axis, seeing from the apex, you can see ventricular septum here, and then this probe is through the VSD, and then aorta more than 80% overriding, and aorta is mostly arising from the right ventricle. So if you look at this case, which has the fibrous continuity between the aortic valve and the tricuspid valve, would you like to call tetralogy of Fallot or double aortic right ventricle, or both, or neither? So the fourth question is that looking at the double aortic right ventricle worldwide, we describe that DORV with the subaortic defect, and DORV with the subpulmonary VSD, DORV with doubly committed VSD, and DORV with remote VSD. And then these three are pretty much straightforward. However, when we talk about the remote VSD, do you have any criteria to say it is remote? Okay. So with that, the priming questions in mind, let's have a few definitions clarified. What is double aortic right ventricle? The definition is both great arteries arising either entirely or predominantly, which means that more than 50% from the right ventricle. So with this definition, you have 1,000 different the double aortic right ventricle. Okay. So with that in mind, it can be described in such a way. Double aortic right ventricle is not a single pathological entity, but it is only one type of ventricular arterial connection. So concurrent transposition or double aortic right ventricle, double aortic left ventricle, truncus arteriosus, single outlet. That is various types of ventricular arterial connection, and this is simply a one type of abnormal VA connection. Both arterial trunks frequently, but not always, supported by muscular infundibulum. Outlet septum within the right ventricular outflow tract. In normal, that is between the right and left ventricle. But however, once it is in the category of double aortic right ventricle, outlet septum is not an interventricular structure anymore. So having said that, this is the answer to the question 3. So this is tetralogy of Fallot with the severe subpulmonary stenosis and 80% overriding. So of course, by the outflow tract morphology, it is tetralogy of Fallot. From the perspective of ventricular arterial connection, it is definitely double outer right ventricle. So we are looking at the one heart from the different perspective, outlet pathology versus the connection issues. So therefore, the two terminologies are talking about different things. So in this particular case, of course, there is tetralogy of Fallot, but there is the double outer right ventricle too. So answer is both. So the double outer right ventricle is a uniformly definable pathology entity. No, definitely not. It is a collection of many, many different pathologies. And then let's talk about a couple of definitions, the terminology we use that in description of double outer right ventricle. What is a ventricular infundibular fold? So the ventricular infundibular fold, which is frequently abbreviated as VIF, is a muscular fold or inner heart curvature that separates an arterial from an atrioventricular valve at the base of the ventricle. Okay, so that is the definition of the ventricular infundibular fold. So here is the arterial valve, here is the AV valve. Between there, you have inner curvature of muscle here. So that is the ventricular infundibular fold. What is the definition of outlet septum? Outlet septum is also known as infundibular septum or corner septum, and that divides the wall between the subaortic and the subpulmonary outflow tract. Of course, in normal, that is between the right and left ventricles. However, if outlet septum is deviated, that is either exclusively right ventricular structure or in the left ventricular structure. So outlet septum is a ventricular structure, but can divorce the one ventricle from the other. Okay. So, oops, why it's not moving? Okay, here we go. So what is the definition of infundibulum? So if the outflow tract has the muscular funnel supporting the semilunar valve, 360 degrees. So that is called infundibulum. So here, pulmonary outflow tract, the outflow tract is 360 degrees muscular. So therefore, the pulmonary outflow tract has infundibulum. However, here, aortic valve and the mitral valve are in direct contact. So there is an outflow tract, partly muscular, partly non-muscular. So therefore, if the outflow tract is partly non-muscular, and that is called that there is no infundibulum or corners. Therefore, we say in normal heart, there is no aortic infundibulum. There is a pulmonary infundibulum. Okay. So that is the discontinuity between the pulmonary and tricuspid valve, continuity between the aortic and mitral valve. Okay. So let's revisit that. So this is open right ventricle in normal. So looking at the septum here, and this is a free wall. So you have tricuspid valve. So you have your septal leaflet, anterior leaflet, or superior leaflet, and posterior leaflet here. And then on the septum, Y-shaped biggest trabeculation. In other words, smooth part of the ventricular septum is Y-shaped. The reason why it is called the trabecular septum marginalis is that if you pass a small probe back here, it can pass to the other side. The other side means that it's coming here and then pass into here. So that is why it is still called trabeculation. But that is very big and is almost always Y-shaped. So this is the body of trabecular septum marginalis, and this is the anterior limb of trabecular septum marginalis. This is the posterior limb of trabecular septum marginalis. And then interestingly, anterior leaflet and septal leaflet of the tricuspid valve has a caudal attachment to the small nipple-like the papillary muscle, which is called medial papillary muscle of Lancisi. And then above that, this the triangular part or half moon-shaped part, that is the septum between the right ventricle and left ventricle, and called as the outlet or infundibula or corner septum. And then toward the parietal side, this is the ventricular infundibular fold. So inner curvature, parietal side, between the pulmonary valve above and tricuspid valve below, that is the ventricular infundibular fold. Okay. And then we should always remember membranous septum is right here at the superior medial corner of the tricuspid valve, on top of the septal leaflet of the tricuspid valve, and that is the area of membranous septum. In surgical field, you are not really transilluminating the heart and the light, so you are not able to see whether it's membranous septum or not. So if you understand this, the distinctive location of membranous septum, if you identify the septal leaflet, and if you identify the medial papillary muscle of Lancisi, and then you can easily identify where the membranous septum should be. Okay, so then they hear that there are a couple of muscle bundles. So they are running from the septal side to the parietal wall. That is called the septoparietal bands. However, actually, it's not necessarily septum. It is not entirely septum. It's it appears to be septum, actually not. Septum stops somewhere here. Okay. So there are some kind of confusing terminology used by European groups and the Bostonians, and then Eastern, the North American group. So parietal band and septal band. What parietal band by Bempra is exactly the ventricular infundibular fold of a European Andersonian language plus outlet septum. And septal band is exactly synonymous with the trabecular septum marginalis. So the Bob Anderson anglicized this, and then now he calls the septum marginal trabeculation. Okay. But I wanted I wanted to use that the origin of that language, trabecular septum marginalis. Okay. So when you have double outlet right ventricle, so this is a cartoon, but however, when you have double outlet right ventricle, VSD becomes the only outlet of the left ventricle, right? And then outlet is divided into subaortic and subpulmonary outflow tract by the outlet septum. And then one thing very importantly we need to recognize is that outlet septum is now exclusively a right ventricular structure when there is double outlet right ventricle. And then frequently between the semilunar valve and tricuspid valve, there is a muscle, and that is called ventricular infundibular fold. If we have a ventricular infundibular fold, aortic outflow tract is muscular infundibulum. Okay. So ventricular infundibular fold completes the muscular infundibulum. Okay. So that is the pretty basics of the terminology we frequently use in the pathology of double outlet right ventricle. But however, double outlet right ventricle is not simply definable because there is spectrum. Therefore, we need to have some criteria, which is called the 50% rule. So if the overriding of semilunar valve is less than 50%, we still think that the great artery belongs to the left ventricle, and this is a sort of discordant ventricular arterial connection. However, here, if overriding is more than 50%, we call that double outlet right ventricle. So therefore, there is a gray zone between discordant connection versus double outlet and concordant connection versus double outlet right. Okay, so that's why I make a joke, and if they becomes to me, oh, this case is double outlet right ventricle, and Osami comes to me and say, oh, this is the transposition. I say yes to both because it is pretty much a transitional area, nothing that worth debating about it. Okay, so in double aortic right ventricle, it is worthwhile for us to think about what is infundibulum really. I talked about it already, but however, let's look at it from the different perspective. In normal right ventricle, pulmonary valve and tricuspid valve are separate because of muscle here. In the left ventricle, aortic valve and mitral valve are in fibrous continuity. So therefore, we use this the descriptive terminology. Discontinuity versus continuity between the arterial valve and the AV valve. Okay, so discontinuity and continuity. The other is presence or absence of crista supraventricularis and absence of crista supraventricularis. At the same time, presence of ventricular infundibular fold and absence of ventricular infundibular fold. Presence of infundibulum and absence of infundibulum. Actually, all of these descriptions, we are describing exactly the same thing using different terms. So that should be clearly understood. Okay, in the short axis, looking at from the heart from the base, this is the left ventricle, right ventricle, the same thing. Okay. So if you have an infundibulum, this is a cartoon of normal heart. You have the tricuspid mitral valve, aortic valve deeply wedged, and pulmonary valve left anterior. So this is the left ventricle, this is the right ventricle. What if the aortic valve moves forward, come to here? And then previously here belongs to the left ventricle. Moving forward, it tends to be connected to the anterior ventricle, in this case, double aortic right ventricle. What if the basic pathology is complete transposition? And then you have your pulmonary valve here, and this is the left ventricle, this is the right ventricle, aortic valve is here. So let's say posterior of the valve is moving forward. Okay, so what is going to happen? Here, that it tends to make the double aortic right ventricle. And then what you have here is that subaortic infundibulum, subpulmonary infundibulum, subaortic infundibulum, and subpulmonary infundibulum. So having infundibulum, what you see is that the arterial trunk supported by the infundibulum is displaced forward and upward to be related to the anterior and connected to anterior located ventricular chamber. Okay. If you look at the lateral view here, if you have an infundibulum, that arterial valve moves forward toward the anterior chest wall. And if it doesn't have the infundibulum, that semilunar valve is away from the chest wall. So as a surgeon, if you see that you're opening the thorax, if you see arterial valve right next to you, and then that means that semilunar valve has the subpulmonary or subaortic infundibulum. If you see that here that valve is deeply into the middle of the thorax, that means that there is no infundibulum or short infundibulum. Okay. So types of infundibulum. So this is the subpulmonary infundibulum. You can have a subaortic infundibulum alone. And then as we discussed in the other cartoon, you can have a bilateral infundibulum. Sometimes, rarely, the infundibulum is absent for both. Usually when you have a bilateral infundibulum, anterior ventricle is usually the right ventricle. Therefore, you have right ventricle, but not always. When you have the bilaterally deficient infundibulum, usually that belongs to posterior ventricle, which is usually left ventricle. That's why double aortic left ventricle is usually associated with bilaterally deficient infundibulum. But however, be sure this is a general tendency, not always at all. Okay. So here is the answer to question 2, which is double aortic right ventricle is characterized by both outlets supported by muscular infundibulum. Why this is hanging around all the time? because when DORV is really beginning to be described in the pathologic literature, they found this one frequently and defined the DORV in such a way, and that the old definition stays very, very long, still that there is a debate. But no question, DORV, this is not the prerequisite as shown here. So you have a bilateral infundibulum here in this DORV. But in this DORV, which is TOF type, there is no subaortic infundibulum. There is subpulmonary infundibulum alone. So bilateral infundibulum is frequently seen in DORV, but not always. False. Okay. So classification of DORV, we usually use, as we discussed already, is pretty long time ago. This is already 50 years ago, described by Dr. Lab, Maurice Lab. Great, but however, issue is what? There are a lot of transitional things. Not really every case can be put into one category. There are cases not able to be in one, or it could be to the other type of things. So that should be also clearly understood. Okay, so this is a representation in the 3D print model. So this is a classic subaortic the VSD with outlet septum to the left margin of the VSD. Okay, and then this is the classic subpulmonary VSD. VSD location could be similar, but the outlet septum is on the opposite side, right side of the VSD, making that VSD exclusively below the pulmonary valve, but aortic valve is isolated. Okay, here, although there is a small infundibular septum, this VSD is mostly committed to the pulmonary valve, but also committed to the pulmonary valve, the aortic valve too, doubly committed. And this is a pretty remote VSD. Okay. So here, however, so we can divide it into that way. So there are significant number of modifiers. So VSD location most frequently between the posterior and the anterior limb, cradled there, but not always. Far from the majority. Is the frequently not there. So what you need to describe when you talk about VSD, at least these 5 major issues to be clarified. One is that VSD location within the ventricular septum, whether involving the outlet part of the septum or inlet part of the septum, or straddling the outlet and inlet, or apical trabecular septum. So that is the VSD location within the ventricular septum. The second is the perimembranous versus non-perimembranous. As a surgeon, you really don't want to make the AV block after the surgery. And then you need to understand the conduction tissue pathway. And then perimembranous versus non-perimembranous is important. Okay? And then orientation of the outlet septum, as I have already discussed a little bit. And then also important is that extent of infundibulum, whether infundibulum is absent, is really long, or it is short, okay? That makes your kind of distance from the VSD very different with the almost identical location of the VSD. And great arterial relationship, whether normally related, side by side, and aorta on the left side instead of the right side. Okay, so this is the location of the VSD. If you look at this 3D print model here, this is a tricuspid valve annulus. This is the aortic valve annulus. This is a VIF, right? And then, how would you describe the location of this VSD? So if I label a little bit, so this is the case. So important thing as a surgeon is a medial papillary muscle of Lanzisi. Why? If we are looking at the VSD from right atriotomy and looking at into the ventricle, and I know that the really view is very small and restricted, okay, and then easily get disoriented. But however, medial papillary muscle of Lanzisi has important landmark, the value. What? If your VSD, if your VSD is on your left-hand side as the surgical view. That is the outlet part of the septum. If the VSD is on your right-hand side, at the surgery, looking at the medial papillary muscle, that means that VSD has inlet extension. That is how you look at whether it is extending outlet or inlet. So medial papillary muscle has that important the issue for the surgeons. And the other is also that the medial papillary muscle, because it has a reasonably constant location, you will see AV conduction axis will be near to there, not exactly there. So from the medial papillary muscle of Lancisi, your conduction axis will be on your right-hand side and toward you. Right? So that is the value of medial papillary muscle of Lancisi. And in this case, I can say this VSD is perimembranous VSD, half toward the outlet, half toward the inlet extension. So what about about here? When the VSD extends toward the inlet, always ask your echocardiographer or MRI physician, give you the short axis view. That is the only way you clearly know how much the VSD is extending toward the inlet. In this, close to the stop frame here, so this is a tricuspid valve, this is a mitral valve, you have a VSD, and the ventricular septum is completely intact along the septal leaflet of the tricuspid valve. And then it is safely say this is a completely outlet extension. However, in this case, VSD stops here, and then this is a tricuspid valve. VSD is halfway of the tricuspid valve. So it is the significant inlet extension. Here in this last case, the inlet septum is here, and then the VSD extends far into the inlet septum. So this is going to have a huge impact in your surgical the orientation. So here in the 3D printing, same case, you have the tricuspid valve here. VSD is absolutely above the medial papillary muscle level of Lancisi here, Lancisi level. Okay, outlet VSD. So this one, so 1/3 of the VSD comes down along the margin of the upper 1/3 of the tricuspid valve. If you look at this VSD all the way down, so without 3D printing, how do you orient this one? Look at the short axis view, not the 4-chamber view. You need to clearly see that the short axis view to understand that. What the problem of the perimembranous and non-perimembranous? So here, perimembranous VSD in morphology, even if you don't see the conduction tissue, if it touches the top of the tricuspid valve, perimembranous VSD, period. If it does not touch the tricuspid valve, that is not perimembranous VSD. Significance of perimembranous VSD is what? Conduction axis is posterior inferiorly running here. So you should be stitching a little bit away from the margin of the VSD. However, if here the VSD is not perimembranous, you know that margin of the VSD is free of conduction tissue, and then you're going to stitch here. Okay, so very simple message is what? Look at the VSD, whether it touches the tricuspid valve or not touching the tricuspid valve. Okay. Next is orientation of the outlet septum. This is the cartoon, okay, showing outflow tract only. So this is the aorta, this is the pulmonary artery, this is the outlet septum. So this outlet septum is fused to the left margin of the VSD, making this VSD exclusively below the right-sided semilunar valve in this drawing aorta. Okay. In this cartoon, the outlet septum goes to the right margin of the VSD, making this VSD exclusively committed to left side arterial trunk, which is pulmonary artery here. Okay. So looking at the outlet septum go to the right margin or left margin defines the commitment of the VSD in imaging as well as in the surgical view. Sometimes the outlet septum does not go to the margin of the VSD. Outerly septum is in front of the VSD, parallel to that. So therefore, the VSD is committed to the arterial trunk posterior to the outerly septum. Okay? So rarely, outerly septum is far from VSD, free floating above the VSD. Okay? So that is why that the VSD can be remote. Okay? So looking at the outerly septum relationship to the VSD margin gives you a good idea about relationship of the VSD to the semilunar valves. Okay? So this is the example. So this is the typical double outerly right ventricle, aorta, pulmonary trunk, and VSD is here. Outerly septum is to the left margin of the VSD, making this VSD below the aortic valve, not committed to the pulmonary valve at all. And in this case, the open right ventricle, aortic valve is here, pulmonary valve is here. Outerly septum goes to the right margin of the VSD, making this VSD exclusively below the pulmonary valve, away from the aortic valve. Okay? So in this particular case, the last one, if you look at it, so the outerly septum is parallel with the rest of the septum, and then outerly septum is in front of the VSD, making this VSD committed to the posteriorly located arterial trunk, which is the pulmonary valve in this case. In short axis, exactly the same thing, showing the same way. You can see outerly septum goes to the right margin of the VSD, and the VSD is here below the pulmonary valve. Here in this case, outerly septum is parallel with the rest of the septum, making this VSD below the posteriorly located the pulmonary valve here. So this is a long axis view of the case similar to the last one. You can see that the left ventricle and right ventricle and aorta here, pulmonary valve here, infundibular septum is just in front of the rest of the septum. And then this VSD is committed to posterior semilunar valve, which is a pulmonary valve. Okay. So the last category is that the remote one like this, okay, here. Okay, here you can see VSD very inlet. The evidence to why this is a septal leaflet of tricuspid valve is all the way down, okay? And then outerly septum is here dividing subaortic and subpulmonary outflow tract, and VSD is remote from the aortic valve, and VSD is remote to the pulmonary valve. Okay. So that's how that the orientation of the outerly septum gives you very good idea about the orientation of the relationship of VSD to the semilunar valve. One thing controversial was this. So previously, Bob Anderson described that absent of vestigial outerly septum means that the VSD is doubly committed. Okay, using this specimen photograph in the literature and lecture. And I argued with him, if I look at this VSD, actually this is exclusively below the aortic valve. Pulmonary valve is nothing to do with the VSD, although there is no outerly septum. So only difference between the TOF in this case is what? Outerly septum is here in TOF, DORV, but in this case, outerly septum is attenuated. But however, I discussed with Dr. Barron the other day, and I realized that if your outerly septum is absent, it's tricky to make a stitch directly here from the right ventricle side. Okay. But however, this VSD is different from VSD extending all the way to the left side below the pulmonary valve. Okay, so these are two examples are great. So here in this case, there is outerly septum. However, VSD is doubly committed. Okay, in this case, there is no outerly septum, but however, VSD is below the aortic valve. Pulmonary valve is nothing to do with the VSD. So which means that absence or vestigial outerly septum does not mean that the VSD is doubly committed. Okay. So another the category is that whenever you have a VSD, people tend to say that is remote VSD. That's not true. So in this case, with the DORV, no question, AVSD is far from aortic valve, far from pulmonary valve. But however, in this case, AVSD, but upper margin of the AVSD extends all the way to the aortic valve. Okay, and then outlet septum is here, and then subpulmonary outflow tract is narrow. Okay, so which means that this tetralogy with AVSD is not necessarily remote. Yes, the low part is remote, but the VSD is directly below the aortic valve. AVSD can extend frequently, actually, in DORV, extend toward the aortic valve or toward the pulmonary valve. Okay. No. So because this a little bit of gray zone, if you look at the literature, how often you see this different type of DORV. So here, subaortic VSD usually 50%. Subpulmonary VSD 25%. Non-committed, if you look at the surgical literature, incidence of non-committed VSD is very high. While that just the imaging literature, it is relatively low. Okay? Which means what? So it depends on, is the non-committed, it's not clearly definable. Surgical literature, not everybody defines it that way. They say if the distance from the upper margin of the VSD to the nearest semilunar valve is larger than the aortic valve annulus, and that is called remote VSD, non-committed VSD. But however, that definition should be modified a little bit. How? If the aortic valve is small, that the simple definition wouldn't work. So if you want to use that, normal, the size of aortic valve, the distance between the VSD margin to the semilunar valve should be more than the normal, the aortic valve size for that particular age. Okay, but however, you don't have to measure it. Okay, I will show you why. Doubly committed, there is a lot of the variation in the literature. So how do you define the remoteness of the VSD from the arterial valve? That is what I asked about. Okay. So here you have 3 so-called remote VSDs. Here you see VSD is rather small along the tricuspid valve. This is the aortic valve. The pulmonary valve is behind this the outlet septum here. Okay, absolutely this is remote. Okay, here VSD is here. Pulmonary valve is far away, but however aortic valve is rather near. In the last one, do you see the last case? I see that the screen blocks it. Okay, wait a second. Let me see. Okay. So here that the VSD is here, aortic valve is here, and the pulmonary valve is behind rather remote. If I show the short axis of these images, this is short axis. So I pass the probe through the VSD. Absolutely, this is far away from the aorta, far away from the pulmonary valve. Here in this case, this is the outlet septum, and this is the subpulmonary outflow tract. This is subaortic outflow tract. Okay, so here the probably, although this VSD is somewhat at distance, but it might be able to be baffled to the aortic outflow tract. Actually, we did. So this one also, this is below the pulmonary valve, although it is remote. So defining the remote, so-called the non-committed VSD, it is important to describe this way. Whether that remote VSD is baffleable to neither semilunar valve or baffleable to the aortic valve or baffleable to the pulmonary valve. So if an echocardiographer or MRI physician comes to you with a remote VSD, you always ask them whether despite the rather long distance, baffleable to the aorta or baffleable to pulmonary artery or not baffleable at all. Okay. Next is the extent of infundibular septum. I made a cartoon for this. So this is intentionally inside of the right ventricle, almost the same. But the only difference is that in this cartoon, the aortic, subaortic infundibulum is short and the subaortic infundibulum is long. If we define the remoteness by the distance, you may say that this is the remote VSD, this is subaortic VSD. So that's why I'm saying it's not really kind of making some rule too strict, right? So that's why that I'm saying, so the one comes to me, this is remote VSD. The other person is coming to me, subaortic. I say to, well, yes. But what I want to make it clear is that this VSD certainly baffle over to the aortic valve, although the baffle will be rather long, okay? What about great arterial relationship? Even if the inner anatomy is exactly the same, if the great arterial position is flipped, so this is a subaortic VSD, this becomes subpulmonary VSD. That's why great arterial relationship is also important. So that is the usual that the morphologist, the echocardiographer's description. But the surgeons try to do differently because that more for surgically oriented, whether that VSD is the like I closed the VSD or I repaired tetralogy fallow, I do the transposition repair with arterial switch operation. Okay, so surgeons try to classify the DORV as a VSD type, TOF type, and TGA type, and non-committed VSD type, and DORV with AVSD, and then DORV requiring single ventricle repair. Okay, I think that is very reasonable. So those are the really major modifiers. There are additional modifiers. So that include ventricular outflow tract stenosis, whether subaortic or subpulmonary, and aortic valve stenosis and pulmonary valve stenosis, obstructive lesions of the aortic arch, and juxtaposition of the atrial appendages, overriding and straddling atrioventricular valves. Okay. So this is a typical the subaortic VSD, that DORV with the subaortic VSD. This is a typical DORV with the subpulmonary VSD. And then here, what happened is that when you have a subaortic VSD, frequently you have a subpulmonary stenosis. If you have a subpulmonary VSD, frequently you have a subaortic stenosis. In the imaging, if you have the outflow tract view in this view, and then you will see VSD is a subaortic, and then subpulmonary outflow tract is small. Okay. Here, when you have the subpulmonary VSD having this cut, and then you see VSD is subpulmonary, and the subaortic outflow tract is shrouded by muscles. Okay. When you have the pulmonary VSD like this, okay, frequent association is coarctation of aorta and interruption of the aortic arch. So when you have your subpulmonary VSD, another terminology is Taussig-Bing malformation, and it is well known Taussig-Bing malformation is frequently associated with the small aortic arch or even interruption. And then you're going to have your subaortic stenosis too. Why juxtapositioning of the atrial appendages in DORV? So this is the embryology cartoon from straight heart tube, and then the moving to the right side, bending to the right, de-looping. Next is what? You need to have your atrium moving toward the right side, and then the outlet moving toward the left side. DORV actually, in some sense, failure of moving of the arterial trunk to the left side. Therefore, atrial appendage is remaining on the left side of outlet. So that's why DORV is frequently associated with the double out, the the juxtaposition of the atrial appendages. So here in this case, clearly double out the right ventricle, no infundibular septum. The VSD is here, and then if you look at this 3D picture here, so this is a right ventricle, aorta, pulmonary trunk is behind. You have your the atrial appendage here, but that is not all right atrial appendage. Part of the right atrial appendage is on the other side, and this is a left atrial appendage juxtaposed on the left side of it. The reason why that happened is that to be transposition or to normal, the outflow tract needs to migrate to the left side, but however in DORV, there is a failed migration. Therefore, atrial appendage, right atrial appendage can be remained partly or completely on the left side of the great arterial trunk. That's why you have frequently partial or complete juxtaposition. So here that is another case of DORV with the interesting one. So if you look at the ventricular septum here, it is pretty slanted to the left side here. And then you have DORV. And then unusually there is subpulmonary stenosis rather than subaortic stenosis. Okay? So what's happening, short axis, if you look at this is two atria, two inlets coming down toward the apex. Okay, so ventricular septum is slanted in this way. So what it is the fact that atrial septum is in this orientation. Okay, ventricular septum is in this orientation. So which means that there is atrioventricular septal malalignment. Okay, in this way. Okay, because of that malalignment, two great arterial trunks arise from the right ventricle, and anterior part of the mitral valve overrides and straddles. Okay. So what it is that this is a cartoon of the transposition seen from the apex, tricuspid valve, aortic valve, mitral valve, and pulmonary valve. What is the pathology is the fact that this the septum, ventricular septum, with the hinge point here at the crux cordis and displaced in this way, leaving two outlets in the right ventricle and then mitral valve overriding and straddling. That is what they call Taussig-Bing malformation with mitral valve. Okay, however, it is a living misnomer. Why? These two are classic Taussig-Bing malformation. So double out right ventricle, subpulmonary VSD. What it is here is that outlet septum is moved to the right side. Here too, you have the outlet septum actually moved into the right ventricle, leaving the ventricular septum in usual position. However, in this case, the outlet is here in usual location. However, whole ventricular septum is moving away from the outlet septum, leaving double outlet right ventricle and the mitral valve overriding. So what is different is that here VSD is confined to the outlet part of the septum. However, when you have a double outlet right ventricle with the mitral valve straddling, VSD actually is large and goes all the way to the inlet too. So therefore, although the literature describes this as the Taussig-Bing malformation with the mitral valve straddling overriding, that is actually different from usual Taussig-Bing malformation. So coronary artery has a variable the origin from the aortic sinuses. Okay, so to summarize what I have discussed up to now, definition of DORV, both arterial, the great arteries arising either entirely or predominantly from the right ventricle. So in double outlet right ventricle, anything happens. Many cases not following the textbook-wise description. Very frequently not able to classify into one of four classes. So that please be flexible in perceiving and describing the anatomy. And then go for the essential modifiers, major and the minor. Okay? So major modifiers, VSD location within the septum, perimembranous versus non-perimembranous VSD, orientation of the outlet septum, extent of the infundibulum, and great arterial relationship. Anatomical issues of surgical importance, always you need to ask to the images. Location of the VSD within the ventricular septum, expected course of the atrioventricular conduction axis, extent of the direct contact of tricuspid valve leaflet to the VSD margin, extent of the muscular infundibulum, available space for intraventricular baffling that requires the measurement of the distance between the tricuspid valve and the pulmonary or aortic valve. And then if there is a quarter of the insertion of the tricuspid valve to the outlet septum. Finally, coronary artery anatomy. Okay, thank you very much for your attention. Okay. Any questions? Yes.
Hi,
Yes.
Dr.Shi, it's a wonderful lecture. Actually, the cartoons and your 3D models has explained the DORV in a beautiful way. So actually, it given us a lot more, like as a surgeon, what we see inside, and exactly put it into the presentation. Actually, I've enjoyed. Be honest with you, I liked it. Hopefully, I can get your recording of this session from Adriana, and then I can use it for my reference in the future. I do have one or two questions. As you said, DORVs, all cases are different in their own way. But I think what you highlighted was the basic principle of any DORV, how to describe what are the important modifiers.
Yes.
So I do have one or two questions to ask you. Whenever we see this kind of, basically I practice from India, so we don't have access to MRI as you do. So mostly we rely on the echocardiography from the cardiologist.
Yes.
So they,
yes.
Right. So what is sometimes scary for a surgeon is they say a lot of cardia from the tricuspid valve is crossing the defect. But when I do this, yes, I just completed, sorry. When I do the surgery, usually I don't find that much difficult to root it. What is it? The cardiologist will always say there's a lot of caudal structure from the tricuspid valve leaflets crossing the defect. That might give you a trouble to root it. But when you do the surgery, you don't find that many of tricuspid caudal substances coming in your way. Is it true, or is it not that being described properly? What is your experience on that?
I think I made the one important point, because the echocardiography literature usually does not describe the way how I described, and then how tricuspid valve is related to the septal leaflet of the tricuspid valve. Most of the time, they rely on the four-chamber view, and then four-chamber view can be higher up in the tricuspid valve, way down in the tricuspid valve too. So therefore, short axis, we're going to give you the more clear picture, and then that will be very nicely correlate with the surgical view, because from the right atrium, what you see will be the septal leaflet right from the angle to you, and below that you will see the VSD, and then coda going down there. So that correlation can be best with the short axis view. So the more I do, the more I really advise the echocardiographer to make the serial short axis view as a kind of standard.
Short axis view. Okay, serial short axis view.
Yes, short axis view. And of course, other views important, but also that you need to pay attention to short axis views.
Sure. And one more question, Dr. Shi-Joon. How about having multiple VSDs in a DORVs?
I would say that we actually had another discussion last Monday. So the VSD was very unusual. So it was perimembranous VSD. It was just touching the top of the tricuspid valve, but extension is mostly toward the anterior wall of the right ventricle. And then in the apex, there are 5 or 6 small muscular VSDs.
Correct.
Yeah, that were not infrequently we see, but sometimes that the VSD is largely missing. So even if it is DORV, you can't really septate it for the difficulty of surgery or even that the concern about the ventricular function after closing it. But I would say these cases are not very frequent.
Thank you again for a wonderful lecture. I enjoyed it.
Thank you.
Can I ask a question, Dr. Shi-Joon? We thoroughly enjoyed your presentation, and the illustrations were really impressive. Just vis-a-vis the entity which Francois Lacarvois describes as a 200% DORV with basically a DORV non-committed VSD. That is the entity when we started operating on these children initially. It was very difficult to understand, but later on, but after a couple of initial cases, we got to understand the entity better. Mostly what we have done is we have routed the LV to PA and done an arterial switch. But I would want to know what would it depend upon where we can actually route the LV to aorta, and sort of what would change in the anatomy vis-a-vis a non-committed VSD situation, whether we could route it to which great vessel. Mostly what we have encountered is it is mostly easy feasible to route the LV to aorta, LV to PA, and do an arterial switch. Is there a contrary situation possible? Because we haven't encountered it so far. We can discuss it later during the course also, because I'm sure it will come up at some stage in this course.
Yeah, I have seen that the number of cases is a lot of variation. So what the variation means is that as the case and cartoon shows, VSD is pretty much in the middle like, and outwardly septum is coming to the top of the VSD, not really coming down, but the hanging around. And then it's equally really distant from the aortic or pulmonary valve. But more frequently, I see that still it is aligned at least with the aortic valve.
Right.
Sometimes it is aligned with the pulmonary valve, but I see that more frequently aligned with the aortic valve and allowing baffling to the aortic valve. The concern is that the too long baffle, the eating up the size of the cavity of the right ventricle too much, and then or the concern about the later development of subaortic the obstruction. But otherwise, that I see that more frequently subaortic still. Or I would say baffle over to the aortic valve. Yes.
Thank you.
Dr. Joon, there is one more question
Yes.
here in the chat. That is a question from Dr. Duyen from NCH, Dr. Chuang's colleague, and he's asking if you could explain the 200% rule in DORV.
Yes. So the morphology of congenital heart disease, we fail if we try to make a too strict definition. So 200% DORV is not really kind of commonly used definition. The reason why we say 200 DORV is the fact that no question is DORV. And then there is long the aortic subpulmonary infundibulum. That is a time when the surgeons used to say 200 DORV. But however, more frequently, DORV, not 200%, more frequently. Yes.
Yeah.
And then 200 DORV does not necessarily mean that is the VSD is remote. No.
Hi, Dr. Shai. We are from Amrita Hospital in India. We thoroughly enjoyed your detailed presentation on DORV.
Yeah.
One question we have is, see, in DORV, when the outlet septum is parallel, or in a case of a very large doubly committed VSD, the cardiologist sometimes say it as a double outlet left ventricle. So how do you as a terminology, how you define a classical DOLV from this subset?
I missed the last words. So how do I differentiate
a classical DOLV from a
DOLV?
DOLV, double outlet left vertical,
Yes.
from a DORV with an outlet septum which is parallel to the VSD, or a DORV with a very large commitment.
Yeah. So it is a matter of how much the displacement tip of the outlet septum is. It's always spectral. Yes. So, but however, classic cases, actually infundibulums pretty short. And then as I meant, that the reason why I talked about the infundibulum, what really is that when you have infundibulum, the longer the infundibulum, the more anterior. The shorter the infundibulum, the more posterior. And then looking at the whether it is DORV, DOLV, or that concurrent or discordant, it all depends on how you get it. I'm very, very opposing to Bob Anderson's description, saying that he always say VSD in DORV, TOF, is the area where surgeons will going to stitch patches. No, in DORV and TOF in this disease, surgeons are baffling the outflow tract using the margin of the VSD. Not really, you're not closing the VSD, right? Yes. And then in that regard, what I mean is that, but however, if you have a little bit of overriding, actually you feel that you are closing the VSD. It's all spectrum. So therefore that when you see they describe in one way to the other, it's arbitrary, yes.
Thank you.
Okay, so I think we should move on. So we spent more than 10 minutes, a little bit more. So David, are you ready?
Yeah, I'm fine. Yeah, but Dr. Tran, did you have a question before we move on? You had your hand up.
Oh.
Yes. Good morning. First of all, thank you for your excellent lectures. I'm a junior surgeon from National Children's Hospital in Vietnam. So thank you for your presentation because I have more clearly morphology in imagination while assisting the DORV repair. And as a junior surgeon, and I noticed in your lecture that you mentioned about the detailed echocardiography scanning. So actually now in our condition that the sonographer, the young cardiologist, while doing the echocardiography, they didn't give us much information. So as a senior emerging doctors, could you give some advice to our cardiologists, or also you have a standardized protocols while doing the scanning?
Mm-hmm.
So could you give some advice to our cardiologists or a kind of protocols while doing the echocardiography scanning for cardiologists?
So basically that myself is not echocardiograph. Although that I do fetal echo, I don't do the postnatal echo. My experience is mostly that the MRI and CT. So therefore that I am afraid that I can be advisor for that. But however, I always help our echocardiographers, and then what you learned doing by cross-sectional imaging, CT and MRI, and then ask them, this is a really great way of looking at, and then would you really modify your protocol in such a way, type of thing. And I continuously advise that our echocardiographer, the more that frequent utilization, the regular utilization of short axis step. And
okay,
otherwise,
thank
it's
you.
pretty straightforward. Yes. Okay. Okay. Thank you all. Okay.
Well done, June. Okay, so let me take over. So we'll move on to our sort of next presentation, which is really just a continuation of what June has just been describing to you, but try to get more of a surgical sort of slant on the way we think about DORV and how we're going to repair it. Let me just share my screen. Are you seeing my slides there?
Yes.
Let me just tidy myself up. So, June's really already given you an incredible journey through the complex subject of DORV, and you'll forgive me because some of my slides are many of June's images, so some of them you'll have seen before. But I think it's perfect that we start talking about morphology, because really, probably more so than any other congenital lesion, I think understanding the morphology is the key to understanding DORV. And I think it's probably the most, really one of, if not the most difficult of all congenital lesions to get your head around, partly because there's so much variety to it, as you've already heard. And I think it's really important to remember it's not only the primary lesion that we have to think about, but it's being aware in each of the variants what the associated features are. So it's a good place to start with these definitions that were really from Maurice Lev of defining DORV by the position of the VSD. But as you know, we've already heard that that's not enough information, but it's still a good place to start, because I think it helps you imagine in your head what the variety is, and it's the sort of definition of the subaortic type of defect, which we've heard is the most common, or a subpulmonary defect. And of course, if the defect is subpulmonary, then almost by definition the aorta therefore is much more remote from the VSD, and you're going to have much more of a transposition type of physiology than you are if the VSD is closer to the aorta. Then we have the more unusual types, which are the doubly committed defect, where the aorta and the pulmonary valve are in direct fibrous continuity. And you've got the remote defects, which are those that often generate the most sort of controversy of whether they can be actually repaired fully or not. And again, here are some lovely examples of the value of 3D printed models that show exactly these sort of 4 types of defect. And it was an interesting question, wasn't it, about, it's all very well having access to MRI to all these patients, and if you don't, then we have to rely on echo. And echo is extremely helpful and accurate and gives you an awful lot of information. But I have to say that having truly 3-dimensional imaging, which is what MRI gives us, does give us an extra aspect of how to really understand these lesions. And it's so much about a 3-dimensional understanding that you can see why this 3-dimensional models or the 3-dimensional imaging that's generated from MRI does take us a step further in really understanding these complex lesions. So remember, the VSD doesn't tell us everything, and it's thinking about those other major determinants. So you want to know about the VSD itself, not only exactly where it is it perimembranous or is it not? What is the relationship of the great vessels? What's the orientation of the great vessels? And what's the arrangement of the outlet septum itself and the infundibulum? They're all going to be important parts of making your decision as to the surgery. And this is just a reminder of just how long we've known and asked the questions about DORV. Was probably first described by a surgeon called John Abernathy in the 18th century at Bart's Hospital in London, where he was fascinated by morphology and found a pathological specimen of a heart like this, where he'd opened the right ventricle and there was clearly the aorta arising from it. And he didn't really know what to call it, but it was the first really recorded recognition that you could actually have a right ventricle that had 2 great arteries arising from it. And over the years, various terminology has sort of been used, with being called partial transposition, through to being called eventually a kind of double outlet ventricle in the 1950s. And it was actually Witham who actually gave it the term double outlet right ventricle. But we've come to understand it, And the definition, as you've heard from June, isn't absolute, because it's just one way of describing ventricular arterial connections. And we have to be careful that there's not an absolute definition. But, you know, as we've heard, you know, more than a half of both the arterial trunks have to be arising from the right ventricle to give it that terminology. But for me, as a surgeon, one of the things I find most useful as a sort of surgical definition of DORV, particularly when you're talking about you know, the spectrum in tetralogy of Fallot, is that it becomes DORV truly when the aorta has moved away from the mitral valve. So instead of the aorta being in fibrous continuity with the mitral valve, it has moved forwards and away from the mitral valve. And so that tells you the aorta has moved forwards, and that lack of continuity means the aorta has come much more anterior. And so you know immediately that your repair, your access to the aorta is much more difficult if you're working through the tricuspid valve. So to remind you of June's comment, when you have hearts like this, which clearly have features of both tetralogy of Fallot and DORV, well, it's both, because the two diagnoses are not mutually exclusive, and so you can be both tetralogy of Fallot and double outlet right ventricle. So we just have to be careful in our wording. You know, that it's not absolute, and some of the areas where the spectrum of one lesion leads into another, then it's a kind of arbitrary definition, and so we don't have to get too hung up on the words. We just need to understand in our heads what the morphology is we're dealing with, so we can effect a proper surgical repair. And again, just a reminder, showing you some of June's lovely images, just a reminder that just think again, you know, why is a left ventricle different from a right ventricle? And in these lovely images of a normal heart, you can see beautifully shown the membranous septum here being transilluminated. But here on the right is the left ventricle, where the aortic valve is in fibrous continuity with the mitral valve, and how different that is from the right ventricle, where the tricuspid valve is physically, you know, distanced from the pulmonary valve. So the pulmonary valve sits on a tube or an infundibulum of muscle. So 360 degrees around the pulmonary valve are formed by muscle, and there's no fibrous structure next to it. So this is the ventricular infundibular fold, and of course there is nothing in the left ventricle to compare to it. And again, June showing you these lovely images, both in a sort of opened out long axis view, but also in a short axis view. And it's just again to remind you that the outflow septum is really a relatively small part of the common septum between the left and right ventricles, and there's only a relatively small area. It's really just this area here, which is actually truly common between a septum between the left and right ventricles. But it's so important to understand the relationship of that structure when you're thinking about DORV. Again, so that's just showing you that really is the outlet septum there. It's not a very large part when you think of the whole surface area, if you like, or the whole commonality of the interventricular septum. That's the only part which is common to the outflow tracts of both ventricles. So what about the VSD itself? Remember, it can be perimembranous, but also it can be truly muscular outlet, and it can be doubly committed equally between the aorta and the main pulmonary artery. So again, it's thinking about what is asking the question, and you say, how do you sort of teach your cardiology colleagues to really give you a good view? You have to sit with them and go through the echoes and sit and look at particularly at the sweeps, where you're looking through the heart with one constant sort of video image, to really try and understand the relationship between the tricuspid valve and the VSD, and the relationship between the great arteries and the VSD. If you take time and look back and forwards again and again, you start to get a real sort of confidence in understanding exactly where you're going to find that VSD, and is it perimembranous, is it muscular, or is it doubly committed? So these images, again, these little cartoons, again, remind us, about how this kind of override sort of business, and what we were just discussing earlier on about what becomes a 200%, if you like, 200% DORV, meaning both vessels come exclusively from the right ventricle. But it doesn't mean it's not correctable, because you could see in this image straight away that it's relatively obvious that you can commit the pulmonary artery to the left ventricle in that situation, and therefore with a switch and then closing the VSD off in this way to the pulmonary artery, you will be able to correct the heart, even though it's 200% DORV. And again, the kind of, sorry, let me go back. The kind of 50% override rule. Sorry. Is again, it's slightly arbitrary. You could argue with this picture on the left that less than 50% of one of the great arteries is overriding, so it's not double outlet right ventricle. And again, it's just no need to get too hung up on the sort of terminology, as long as you really understand how you're going to affect a repair. And again, as we move along, just to think about, as Jude has emphasized, the importance of understanding about the infundibulum, and the fact you can have two, or you can have bilateral infundibulums, with both the great arteries really arising on a tubular structure. But it's not necessary to define DORV to have two infundibulums. They don't always have it. You can have really absence of the infundibulums when you have a doubly committed type defect, or you can have either the pulmonary or the aortic valve on an infundibulum, but not the other. And typically, we recognise in the sort of tetralogy of fallow type DORVs, then the aorta does not arise on an infundibulum. We recognise that, or if it is, it's a very short one. Here's a sort of example saying how the length of the infundibulum is variable. See how long it is. An example on the right, leading it right out to the aorta that really is sitting on a long infundibulum. So how much more difficult it's going to be to create a tunnel that aorta from the left ventricle, whereas sometimes the infundibulum is really very short, as in this typical sort of tetralogy type DORV. Exactly the same, just showing you here with some of these PDF generated three-dimensional images. Again, just reminding you of understanding the relationship between the infundibulum and how that's going to relate to the VSD. So clearly in this top image, you've got a subaortic VSD that's relatively remote, but it seems to still be committed to the aorta. And there is a long infundibulum, and the long infundibulum means there's going to be a longer channel to commit that through. And again, I think a lot of the debate we've had is about, when does a remote VSD become truly remote? And I like the definition that it's when the distance between the margin of the VSD and the aorta is greater than the diameter of the aorta, or at least the predicted diameter of the aorta, for that age and weight. So this would be a remote VSD by that definition, but it still looks to be readily committable, albeit with a relatively long baffle to achieve that. Again, at the bottom, much more of a tetralogy type lesion. So that's Maurice Lev, who really gave us the definition, or the original classification of DORV. But again, just to go back to what June was saying, remember the major variables. So we can't define it only by the VSD. Remember, we've got to think about the position of the VSD within the septum, ask the question, is it perimembranous or is it non-perimembranous? And you remember, you can easily get a VSD that is both perimembranous, doubly committed, which becomes a very extensive type of defect, but it does exist. So you have to be clear in your head before you're going into the operating room, how are you going to approach this VSD? Think about the orientation of the outlet septum and how extensive or how present is the muscular infundibulum. And then probably most importantly is understanding the great arterial relationship, because it can be very variable in DORV. Again, so here's clearly a perimembranous type VSD, which is subaortic and readily committable through to the aorta. But on the right here, a muscular sort of doubly committed type defect, which has moved away from the perimembranous region, but is doubly committed beneath the two vessels. So the conduction here would be right along the inferior margin of the VSD because it's a perimembranous defect, but here it would have moved away from the edge and you'd be safe to put your sutures in the edge of the defect there. But again, just reminding you that the relationship, in thinking about all of these things, we just want to think about what's the relationship of the VSD to the infundibular septum or the outflow septum. So again, here where it's clearly a subaortic defect, it's effectively fused to the outlet septum there. On the here it can be subpulmonary, where the outlet septum is really fused to the right-hand margin of the VSD. But equally, you can have this distance here in a more remote defect, where the outlet septum has become more parallel to the plane of the VSD, or here where it's more remote again. Neither parts of the infundibulum are really related directly to the VSD because it's become so remote. And again, these are I guess again just examples trying to show you of that variable relationship between the VSD and the outflow tracts and the infundibulum. So I don't want to overplay all this, but it's just I think trying to get in that mindset of thinking about all the variable components. When you don't just think about where the VSD position is, you're thinking about how does it relate to the infundibulum, how does it relate to the great arteries themselves. But I want to sort of move on more to the more surgical sort of components. So a reminder that the distribution, that really more than half of these sort of VSD positions in the setting of DORV will be subaortic. And the next most commonest is that the defects are really subpulmonary. And the less common variants are those that are truly non-committed or kind of remote VSDs. And then the rarest of all are the ones that are doubly committed. So they're really quite unusual. And again, just seeing how these are examples of trying to work out from the three-dimensional models, how are you going to commit the VSD through to the great vessels? Are you going to baffle it to neither, because it's really genuinely too remote? Are you going to baffle to the aorta, or are you going to baffle to the pulmonary artery? Which all depends, on the position of the VSD and the relationship with the great vessels. And again, June has shown you some of these images where you're just trying to understand whether it's more inlet, whether it's more outlet, or whether it's truly remote in terms of the VSD position. And again, a combination of MRI and echo really gives you a good understanding. And it's that short axis image, which is really helpful in seeing here, where it's very much an outlet VSD, and you can immediately see really the pathway through from the left ventricle to the aorta. It's here where it's more inlet, and now the tricuspid valve is getting more kind of in the way if you're going to be able to commit this through to the aorta, and then having a 3D model is therefore so helpful in working out your pathway. And here where you've really very much an inlet defect, and that's going to be again more difficult to commit that through to the aorta. And so that really brings me more to the kind of surgical classification and the reason which we've discussed today about why really defining just by the VSD isn't always that helpful. And I think there was a lot of work that was done as a combined reclassification by both the STS, by the European Association, and the AEPC, the Pediatric Cardiology Association, that really came up with I think a very practical classification of VSDs in DORV. And it breaks them up into these 4 types, which I think are very helpful, because really that really defines them by the way you're going to repair them. So they're either a VSD type, meaning they're subaortic, and they're clearly a straightforward baffle from the LV through to the aorta, or they're the tetralogy type, which we all recognize as a sort of subtype of tetralogy morphology with a multi-level obstruction to the pulmonary the pulmonary and subpulmonary region, and with a large overriding aorta committed through a perimembranous VSD. Well, usually perimembranous, it can be outlet muscular. And then the transposition type is where really treatment is usually achieved through performing an arterial switch and then committing what was originally the pulmonary artery through to the left ventricle, really because the VSD is therefore subpulmonary by definition. And then the rare types are the truly non-committed VSDs, where committing or correcting a biventricular repair can be more challenging. But don't forget the associated abnormalities. You can have outflow tract stenosis of one of the outflow tracts, which can be either subaortic or subpulmonary. And you can, of course, have obstructive lesions of the aortic arch. You can also have juxtaposition of the atrial appendages, as June has mentioned, and you can have straddling or overriding of the AV valves, which is often really a surrogate marker telling you that one of the ventricles is small and underdeveloped. And those are the cases which may genuinely not be septatable. So again, just sort of going again once again through these ideas here, the subaortic defect, the subpulmonary defect, where you can see the ready way to correct this is by committing the left ventricle through to the pulmonary artery. And here you can have stenosis with a subaortic defect. Here you've got stenosis of the pulmonary valve, and here in the bottom image you've got the subpulmonary defect, and you've got stenosis of the aortic outflow, and the sort of positional deviation of the outflow septum. And again, here just showing the same here with a sort of Taussig-Bing type heart, which we'll talk about in a moment. You can see how you can end up with obstruction with a relatively small aortic or subaortic region due to the deviation of the outflow septum and a very large and dominant pulmonary artery, which, as I say, you'd hopefully correct by performing an arterial switch. So let's move on. We've talked about this enough. We've understood about the important things to take on board when assessing all these difficult hearts with DORV. So remember about the location. Got to think about where the AV conduction axis is going to be. Think about, is the tricuspid valve in continuity with the VSD margin? Think about the infundibulum, how long it is, how extensive it is, how does it relate to the VSD? And think about the space you've got between the tricuspid valve and the pulmonary and aortic valves, because that's going to be an important part of some of your intraventricular baffling in order to try and get a corrected physiology and a corrected anatomy. Let's think about DORV sort of transposition type for the last few minutes. Again, that just reminds you of the sort of relative commonality of these conditions, and we're really going to talk about subpulmonary defects. Yeah, so these account for about a third of all DORV, and they're some of the most challenging ones to correct, but in general they are suitable for biventricular repair. And having a subpulmonary defect really tells us that the aorta is remote from the VSD. The aorta is anterior and it is more distant from the ventricular septum than the pulmonary route is. The arterial trunks tend to be relatively parallel, or even with the aorta more anterior than the pulmonary artery. So the aorta really has moved a long way away from the mitral valve. And the definition of Taussig-Bing is a double outlet right ventricle with a subpulmonary VSD. So that is the kind of textbook definition, but in reality, the vast majority of these have got a sort of transposition type of physiology. So about 2/3 of them are side by side, usually with the aorta just ever so slightly anterior to the pulmonary artery. And about 1/3 of them are more AP, really more like a regular kind of transposition with the aorta anterior and to the right. And again, think about the relationship of the septal arrangement, and it can be more of a kind of trapdoor type deviation of the outflow septum in many of these cases. Here you see with the pulmonary route and valve really overriding the plane of the ventricular septum, and the outflow septum has become rather sort of hinged across like a trapdoor that makes the subaortic outflow relatively smaller. Or it can, in other cases, be more of an en bloc type of deviation of the outflow septum. So again, you've got the pulmonary valve sort of overriding the septum. But here, because it's not such a hinge type kind of mechanism or movement of the outflow septum, then the aortic and subaortic region tend to be larger. And again, here's some examples of both. See how it's really kind of deviated here, the outflow septum, it's hinged across, and it makes the subaortic region relatively small. Whereas in this sort of en bloc movement, you can see this is the plane of the ventricular septum, and here's the plane of the outflow septum, where it's just moved across en bloc to the side. We don't tend to get such a small subaortic region in that setting. So how are you going to correct these sort of hearts? Well, here's a sample from Bob Anderson here, beautifully kind of shown. Here's the subpulmonary defect of Taussig-Bing. Here's the outflow septum. So this is the pulmonary route here, and this is the aortic route here. Both a good size, but you can see how difficult it would be to commit from the LV through the VSD to get it all the way to the aorta. Very difficult because it's almost obstructed by the outflow septum that's in the way. And so it's immediately obvious that the arterial switch is a much more attractive option. You simply have to commit the VSD through to the pulmonary valve, which is already almost overriding the defect, and then perform an arterial switch so that this becomes the aorta. That's very much become the preferred way to correct Taussig-Bing type anomaly. There is an option of intraventricular rerouting, which I'll talk about later on, but that involves creating an intraventricular baffle to commit this subpulmonary defect across to the aorta. So what are the features? Remember, we talked about how important it is to think about the associated lesions. So it's not just about recognizing that this is a Taussig-Bing, recognizing that this is a subpulmonary defect and that an arterial switch is going to be the best way to correct it. You then think about, well, what do we know are the associated lesions with transposition type of DORV? And they're very characteristic, and arch hyperplasia and coarctation are very common. So about half of the cases are going to have some degree of arch hyperplasia and coarctation. And probably the morphological reason for that is that when you have this sort of lesion with a large subpulmonary VSD, then during fetal development, you're going to get very dominant flow through the VSD into the pulmonary artery. So you get a very large ductal arch and preferential flow throughout fetal development through the ductal arch of the pulmonary artery. So you tend to end up with a very large pulmonary artery and relatively less flow around the true aortic arch which can lead to underdevelopment or smallness of the whole arch. And where the small arch meets the large ductal arch is where you may well end up with a coarctation. So the whole thing is set up to develop arch hyperplasia and a small arch, and even in some cases interruption. So the next thing we know is commonly found in transposition type DORV is that the great vessels tend to be side by side, usually with the aorta slightly anterior. The VSD is usually perimembranous in the majority of Taussig-Bing cases, but it can quite commonly be a muscular outlet VSD beneath the pulmonary valve. And the next thing to think about is that, as we know from our experience in transposition, is that as soon as the great vessels are side by side, then you get much more you get much more abnormal coronary patterns. Excuse me. So more than half of the cases will have abnormal coronary patterns, and almost all of these are retropulmonary circumflex. So the Yakub definition is of the type D and type E coronary patterns. That's type D is where the right coronary and circumflex come off together from sinus 2. So the circumflex goes behind the pulmonary artery. And type E is where the circumflex comes off on its own from sinus 2 and runs behind the pulmonary artery. So common to get these abnormal coronary patterns. And of course, that we know that makes the arterial switch a little bit more challenging when you have this abnormal type. So the more side by side the vessels are, the more likely you are to have abnormal coronary patterns. If they are more AP in relationship, then you're less likely to get the abnormal coronary patterns. So I think the question that's often asked in terms of managing Taussig-Bing with arch obstruction is, should you do this as a single staged all-in-one repair, or should you do it as a staged approach? Because doing an arterial switch, the VSD closure, which of course is not a simple VSD closure, it requires a bit of time and thought to commit that VSD through to the pulmonary artery, and you've got to do a switch, and you've got to do an arch repair. That's a lot of surgery in one lot. So the question is, should you break up the surgical kind of insult and do an arch repair and a pulmonary artery band, and then come back and do your switch and VSD closure afterwards? Or should you do it all in one? And there isn't a right answer to this. It's been debated for many, many years, and I think there are situations where either approach is perfectly reasonable. Of course, if you do go with an arch repair and band, the risks are particularly that you may leave them relatively cyanosed, because remember, this does tend to be a cyanotic lesion. If you're placing a band, you're obviously going to limit their pulmonary blood flow, and so they may become more cyanosed as a result. So that's always going to be a risk, but usually it's tolerable. But the question more, to my mind, is, remember we were looking at the fact you tend to get a deviated outflow tract, deviated outflow septum, and that you may have, therefore, a risk of subaortic stenosis or relative sort of hypoplasia of the immediate sort of subaortic outflow tract. So if you perform an arch repair and band, you may be leaving the baby with a relatively small systemic outflow tract, and so a risk of relatively low cardiac output. So that is a risk of going with the arch and band type approach. And I think if you're going to go with that approach, you've got to be confident that the subaortic region is adequate, and you may need to address it at the time of the arch repair and band if you're going to go with that single approach. So I think you can go with either, because there's not much real true evidence in the literature to say one approach is better than the other. But I would say that the studies that have the better outcomes have been those who've gone with a single stage complete repair. So I do think the pendulum is swinging generally towards, if possible, going for single stage neonatal repair of the entire lesion. And I think in my mind, the only situations where I might consider a staged repair is in the setting of maybe multiple VSDs, as we mentioned today, which you can be, where clearly that's going to be more difficult to repair as a neonate, and many apical muscular VSDs will spontaneously close if you can wait with a band on for a few months. And also cases where you're worried about the size of the right ventricle, which can be combined with straddling of the mitral or tricuspid valve. So these are just some really nice images that I've stolen from the Operative Techniques textbook. They're from Baha Al-Sufi, who was a trainee in Sick Kids. And they're very nice pictures, I think, because they really show all the typical associated problems with Taussig-Bing, and also, I think, show exactly, how I would approach these sort of problems. So if you look at this lovely diagram, you can see the side-by-side vessels with the big mismatch in size of the great arteries. So typically a very large pulmonary root and a much smaller aorta. And here, look at the hypoplasia of the transverse arch and the coarctation. And then if you look at the coronary pattern, you can see there's an abnormal coronary pattern with the LAD and the right coming off together. The sinus 1 and sinus 2 is giving off a retropulmonary circumflex. The typical set of problems for a Taussig-Bing type heart. So again, this is how I would approach it if we're going to involve an arch repair. I think having a graft placed on the innominate artery for your arterial perfusion is very helpful, because it allows you to run your head and neck perfusion when you're doing your arch repair without having to do any recannulation, and you haven't got any cannulas in your way for doing your arch repair. So that's how I'd set things up: bicable cannulation and an arterial cannulation in the innominate artery, and then the reconstruction is going to involve complete opening up and patch repair of the small aorta. And again, one of the advantages of doing all this as a single stage procedure with a full repair means, of course, you do your full resection of coarctation and interdigitating repair into the descending aorta, and then a patch augmentation of the arch. So you've transected the aorta where you're going to do your standard position of transection, as you would do for the arterial switch. And of course, that then means that your patch comes all the way down and augments your aorta right down to the point where you've transected it. So immediately you've created a much larger sized ascending aorta. So when you've done your Lecomte maneuver and you're reattaching your neo-aortic anastomosis, you've already addressed that mismatch in the size between the aorta and the large pulmonary root by the fact that you've patched it at the time of your arch repair. So that's a useful way of doing it. So you do this full arch repair with the patch coming all the way down. The coronaries come out in a standard way, and are reimplanted in exactly the same way as you would for any arterial switch. But this is really important, yes, before you close, you kind of carry on with the surgery, is look down through the neopulmonary root. So this, remember, was the aorta, where we've taken the coronary buttons out. Now we look down through that outflow tract, because quite common, you've got muscle bars or outflow septum that's protruding underneath the valve. It'll create subpulmonary obstruction if you don't address it at this stage. So it's really important to look down through what's going to become your pulmonary outflow tract before you close it all up and carry on with the arterial switch. So resect any muscle bars, make sure this is maximally open so you don't leave them with subpulmonary obstruction. And then when it comes to the Lecomte maneuver, because the vessels are side by side, it's often very helpful to move the opening in the pulmonary arteries across to the rightward side, so that it much more accommodates the side-by-side nature of the great vessels and avoids you putting too much tension on the left pulmonary artery, which may then pull the pulmonary root against the coronary arteries. So by moving the opening across, you address that side-by-side nature. So I think these pictures really summarize a nice way of approaching all the associated abnormalities that we recognize. with Taussig-Bing. So again, you can look in literature to look at outcomes of people who've used predominantly the arterial switch as the way of correcting a Taussig-Bing anomaly. And certainly you can see, that in many series, really the outcomes are pretty good, but none of them are without any early mortality. It is quite a complex lesion to repair, and it's reflected in that. And you can see why when you see how common it is to have these challenging lesions of abnormal coronary patterns. And here you can see that as soon as you've got an abnormal coronary pattern, then the outcome is not so good. And almost all the risk is associated with abnormal coronary patterns, it would seem. Another feature, I think, of Taussig-Bing repair is that intervention rates are relatively high, for all the reasons we can understand, because the anatomy is so challenging. So an intervention can be both on the left or the right outflow tract. So you do see, particularly problems if you're unable to baffle the pulmonary artery well enough through to the aorta, then you may end up leaving them with sub-aortic obstruction or outflow tract obstruction, or you may of course have residual aortic arch obstruction following your aortic arch repair. So it's not, it is a feature in both the left and right outflow tracts that you may get recurrent problems in these patients over the years, much more so than you would see in kind of regular transposition. So just quickly to mention that there is another approach to Taussig-Bing, or to double outlet right ventricle with a subpulmonary VSD, and you can do an intraventricular rerouting, and it's called the Kawashima operation, and it's not done very commonly because it does require quite sort of convoluted intraventricular repair. It has to be really done through a ventriculotomy, and you can see the VSD shown here, and you can see the outflow septum here, which is deviated beneath the aortic valve. And so if we're going to achieve an intraventricular baffling, we need to resect that outflow tract septum, as you can see in the middle picture here, so that you created an open pathway between the VSD and the aorta. And the key feature for a Kawashima to be possible is that the distance here between the pulmonary valve and the tricuspid valve has to be at least the diameter of the aorta, the diameter of the aorta, for that predicted size child. So that otherwise the pathway is going to be too small. So you have to have enough room here, enough diameter for your baffle to be able to commit through. And here's the baffle shown here, all the way through from the VSD across to the aorta. And you can also see be very easy to create subpulmonary obstruction here if you're not too careful. So you often may need to place a patch into your ventriculotomy rather than closing the ventriculotomy directly, or you may end up having created subpulmonary obstruction. So it can be difficult to do this, and it's generally reserved for older children. So usually these children have had a pulmonary artery band as a first intervention, and then they have their Kawashima repair done later on. It has been done in small numbers, but I think given how successful the arterial switch has been, it seems that it's really unusual to need to do this. Maybe you could argue that patients with with abnormal coronary patterns, where you're uncomfortable about doing the arterial switch, this is a good way of avoiding having to do an arterial switch. But you can see it does require making quite a long intraventricular tunnel with a risk of developing sort of subaortic or outflow tunnel stenosis over time. But again, here's another example showing the same, the Kawashima tunnel. And as I say, it can be done with complex coronary anatomy. And I think very rarely, just to mention some really unusual situations, you do very occasionally get situations such as this, where you've got your subpulmonary VSD, but you've actually got pulmonary stenosis, which is very unusual, but it is recorded in this paper from Fuwai in Beijing. This was actually corrected by doing a double root translocation. and then committing the VSD through to the aorta. So pretty extreme surgery, but it can be done. So just to summarize all of that, this is where I'll stop. But particularly thinking about the Taussig-Bing anatomy is that the definition, remember, really is a subpulmonary VSD with double outlet right ventricle. I think the arterial switch is the preferred approach. Remember the associated features. I think primary neonatal repair, if possible, is the best way to approach this. But staged repair is perfectly reasonable. And if you're going to do so, be sure you're not leaving them with subaortic stenosis. It's inevitable that intervention rates will be relatively high compared to regular transposition. And intracardiac rerouting is rarely used, but is an option for older children. Right, sorry, you've had a lot of people talking at you. I hope that's been useful. I'm going to come back in. And we can perhaps have a chance to draw breath, and if you have any questions.
Hi, David. This is Adriana. Thank you so much for this wonderful presentation. There was a question in the chat, it might be from a little bit earlier, but I just wanted to make sure we had a chance to mention it. It's a question from Dr. Behera from Artix in Kolkata. He's asking which DORV should go to single ventricle pathway, absolute indication for single ventricle pathway in DORV with remote VSD.
Yeah, well, it's a very good question. And it's one of those, I mean, the truth is it's unusual. I think if you have two, well-formed, normal-sized ventricles, then the vast majority of those cases, you're going to be able to achieve a biventricular repair. And obviously, if the VSD is subaortic or subpulmonary, then it's not. It's pretty clear how you're going to be able to affect an easy biventricular repair. And I think, as you said in the question, that the problem is the truly remote VSDs. So VSDs where where there's a long distance from the VSD to the nearest great artery, that immediately creates a problem. But usually, even in most of those hearts, as long as the right and left ventricles are both of normal size, then you will be able to devise a pathway through from the VSD to one of the great arteries and therefore achieve a biventricular circulation. And that's going to be true in the vast majority. The ones where you're not sure are where there's an imbalance in the size of the ventricles. And so, and that's typically where you've also got straddling of one of the AV valves. And in that case, often, typically the right ventricle is actually a little bit small. And suddenly that's where you're not sure you're going to be safe with a biventricular repair. And I think, when it really isn't clear that you've got an easy way of achieving a biventricular repair, and it's very unusual, but it is not a sin to go down the pathway of a Fontan type circulation, because that will still be a safe option for the child. And I think there's no kudos or benefit in pursuing a biventricular repair when you feel the intracardiac anatomy is so difficult that it's not going to be achieved easily, because trying to go all out and create a biventricular circulation at the expense of a very long, convoluted, small left outflow tract will probably not do the patient any favors. So it's why I think the imaging is so important to making that key decision right from the outset. I know, June, do you have any thoughts on that?
No.
It's pretty unusual to be truly, unseptatable for most of these hearts.
That's good.
Yeah, go ahead.
Dr. Barron, can I ask you a question?
Yeah, go ahead.
Yeah, so what is the correct terminology should we use for Taussig-Bing anomaly with the anterior or posterior relationship of the great artery Because according to your slide, so 30% of the patient with Taussig-Bing anomaly have anterior posterior relationship. But truly said that some surgeon still use the Taussig-Bing terminology for only side-by-side great artery. So can you comment about this terminology for Taussig-Bing anomaly?
Yeah, sure. I think that the message is just not to get too kind of obsessed about the exact morphology. You know, Taussig-Bing is a double outlet right ventricle with a subpulmonary VSD, and the great vessels can be either side by side or they can be AP related. So for me, it doesn't really matter which version which it is. It's as long as if it's a DORV with subpulmonary VSD, then that's Taussig-Bing. I mean, as surgeons, we need to understand how we're going to repair it, and so we don't need to get on the morphology. If you want to call it transposition, you know, physiologically it behaves like transposition, and the repair requires a switch. So I don't really get too worried about it. June, what do you think?
So I think it's the interesting question, because that the basically definition of Taussig-Bing now currently used originate from one case report.
Yeah,
not really series of cases. So therefore, there is a lot of argument in the literature whether such a heart can be called as Taussig-Bing. But however, in 2022, pretty consensus is that DORV with the VSD involving the outlet septum, outlet part of the septum, and then VSD is the exclusively underneath the pulmonary valve, regardless of whether it is side by side or anterior posterior relationship. More frequently, it is side by side. But if it is side by side, I think I'm not a surgeon, but however, I'm concerned about Lucombe is some issue, instead of if it is more anterior posterior with outlet septum parallel unblocked displacement, and then is there like arterial switch operation quite easy, but that might be a little bit of issue, different issue. What do you think, David?
Yeah.
Dr. Barron, good morning.
Hi.
I am Dr. Mishra from PGI Chandigarh. I want to ask you one surgical question related with Taussig-Bing with arch hypoplasia. One of my case, when I enlarged the arch with patch, I found that it was redundant. Then I have to revise it, and I could directly connect the ascending aorta and descending thoracic aorta, and then that gradient abolished. What I mean to say you that, is it required to put a patch there?
I didn't quite. Do you require a patch all the way down the ascending aorta? You mean?
Yeah. I think patch might cause.
Yeah, because the size of the ascending aorta is variable. So the size of the ascending aorta is variable. And if it's a good size, you may not need to bring the patch all the way down. I agree, but usually there's quite a big mismatch in the size between the ascending aorta and the pulmonary artery, and making up that difference is quite difficult. So if you've got the opportunity to put a patch in, I usually do.
My point is that in case of Taussig-Bing with anterior posterior relation more of, if you do LeCompte, you do not need the patch for the enlargement of arch. You can directly connect the ascending aorta and the descending thoracic aorta, because putting patch to enlarge the arch might cause redundant and it can cause kinking of the aorta.
I've not encountered that.
What is your experience?
You often have quite extensive hypoplasia of the arch, and I think you really have to use a patch if you've got true hypoplasia of the transverse arch and ascending aorta. So I would usually find you have to use a patch for those. I mean, remember that that 50% of Taussig-Bings don't have any arch hypoplasia and they don't need a patch. But we're just talking about those that have got arch hypoplasia.
Thank you. Thank you.
So Dr. Raju has a question, right?
Yes. Is Lecomte maneuver recorded in all cases of Taussig-Bing anomalies?
I think so. Yeah, I mean, you always hesitate to say always, but in general, even when they're side by side, the aorta is slightly anterior, and so usually the Lecomte is the right thing to do. It allows the arteries to sit more comfortably. So I've never come across a case where the aorta was more posterior. So I've always done a Lecomte for the Taussig-Bing type repair. And as far as I know, looking in the literature, it's pretty much well described that everybody uses a Lecomte.
Thank you, sir.
Dr. Raju, you have a question?
Yes, Dr. Barron, thanks for that wonderful lecture again. I think both you and Dr. June has given us a clear picture on DORV. I do have a couple of basic questions. Basically, in a DORV with a remote VSD, say the VSD is kind of aligned towards aorta, how often do you use a two patch? Do you use a single patch, or when do you do two patch? Second, yes.
Yeah.
I do have one more question. The same when the septum, which is infundibulum septum beneath the aortic valve, even though it's not obstructive, do we have to go and resect that septum all the time when you close the remote VSD to the aorta?
Two patches, I don't tend to. I certainly recognize people have found it useful. Personally, I try and always do it with a single patch. I think sometimes people have described taking a patch from a curved graft to kind of create a natural curvature to the VSD baffle pathway. I usually don't find a need to. I just use something simple, soft, and the key is making sure your patch is wide enough. I've usually always tried to do it with a single patch. I find it easier, but I perfectly recognize people have described two patches, which creates more of a kind of dog-legged shape, which can be quite useful. So I think there's nothing wrong with the two patches. If you choose to do it, I usually use one. And you said, do you have to resect the outflow septum? Not always, no. I think it's purely whether or not it's actually impinging on your outflow tract pathway. I mean, you're obviously you want to make your subaortic pathway, the kind of baffle, as voluminous as possible, as big as possible. So if the septum is really deviated beneath the valve, so it's actually hiding the aortic valve from you, then it may be worth doing. But I wouldn't resect it if it's not actually in the way. We've got we've got a little example we can show in a few minutes just to show that, I think.
Okay. And I have one more question to ask. Is that okay to proceed?
Yeah, go ahead. Yeah, go ahead.
So, the children with the DORV, multiple VSD were multiple chordae from the tricuspid leaflets crossing the VSD with the PS, relatively well balanced, say saturating around 80–85%. When do you plan a repair? What's your timing of repair in that kind of well balanced circulation?
Sorry, well balanced in the sense they've got you've put a band on, or
no band, just a valve PS is there, say moderate to severe pulmonary stenosis, and
yeah. Well, yeah, I mean, if there are multiple VSDs, you often want to try and give some time because a lot of the sort of muscular VSDs are going to close, hopefully, over time. So as long as the patient's well balanced, as you say, and stats of 80–85%, they should be perfectly safe, really, to wait for as long as you need to. So I guess they'll declare themselves, as long as you're comfortable that they've got enough pulmonary stenosis to protect them from over-circulation or from developing pulmonary vascular disease. As long as that's the case, they're going to be safe to be left, for years if needs be. Usually would affect the repair before a year of age, I guess, in reality, in most of these patients. But if they're balanced and stable, you can wait.
Okay. And last questions: how do you deal with these children coming back to you with LVOTO?
Yeah. Well, so yeah, I mean, obviously, that can be quite difficult. You really got to decide. Again, good quality imaging, MRI and echo will help you get an understanding of what you're dealing with. And, you know, sometimes you do simply generate, you can do as fibromuscular tissue in the subaortic region that you can resect to effectively enlarge it. And that's, you know, part of that is simply the residual outflow septum that's in the way, but also, you know, if you've got turbulent flow, it can generate fibrous laydown of tissue, and you may end up with a fibrous tissue in the outflow tract that you can resect. So sometimes, if you're lucky, it's simply a case of resecting a sort of fibromuscular tissue working through the aortic valve, but very commonly you may find you've actually got to redo the VSD patch to recreate a larger baffle in those patients, and you usually need to do it through a ventriculotomy, I find, to really get good access to the outflow tract.
Oh, thank you, Dr. Barron.
Okay, so I think the Palm finished the editing of the old videos, David, you did today.
Yes.
I need to make one comment here. So this meeting, without the Brandon Peel and the Palm Saprung Wang, our fellow from Thailand, it's really difficult. But the happening was that the David and the Palm recorded all two cases a few days ago. And then at the end, that the Palm was almost crying, it collapsed because that there was a computer issues, and then recording is gone. So that's why today, David and the Palm recorded again today, and then it's all available now. Palm, thank you very much. Okay, so go ahead, David.
Thank you, Pal. Yeah, absolutely. Yeah. So Brandon is the manager for our whole 3D printing program, and he organizes all of this. He gets all the models out to you. He organizes all the Zoom links, makes sure everybody's here on time. He does a fantastic job, and we're incredibly grateful to him. And Pam, who's our MRI research fellow, has helped create a lot of these images and models and video, and creates all our videos for us. And she's an incredible talent. So we really benefit from their skill and help. So Pam's got these two videos, which is going to show. So these are the models that you'll be working on next week. And I think we'll just have time to do the two today because the Taussig-Bing is more complex. So we're going to focus on a kind of remote, if you like, or, you know, a remote VSD that is committable through to the aorta as the first case. And the second really is a case with a sort of doubly committed type of defect, or at least a defect where the aorta and pulmonary artery are in direct fibrous continuity. So we'll just show you quickly some edited video just to show the principles of the surgeon, hopefully what you'll be able to do with us next week, and gives you an idea of what the models are like to work with. So Pam, are you able to show on the screen the first video?
Can you see now?
Yep.
No?
Yeah. Yep. It's okay.
Yeah, can you see it now?
Oh yes, now yes.
Yeah. Thanks, Pam. So again, so here we are with one of the models that you all have. So here's an example where you've got pretty sort of side-by-side great vessels, clearly double outlet right ventricle, but a very much kind of remote type of VSD, much more in the inlet perimembranous region. So there's a sort of example that you could see it there on the PDF model. There's the very inlet type of VSD. You can see here the medial papillary muscle of Lancisi, which is really Stradner defect. So it's both inlet and outlet, but predominantly inlet. And although you can imagine the pathway through to the aorta. It's got that definition where the distance between the aorta and the VSD is greater than that of the aorta. So it's definitely remote, but you can still imagine a pathway to connect that VSD through to the aorta. So here's the model. And again, just sort of showing you those rather sort of side-by-side great vessels clearly sort of both arising from the right ventricle. And they've got a little kind of peephole in them, so you can look inside the right ventricle, and there you can see the VSD very much in the inlet, and the papillary muscle rather kind of rather sitting across the VSD, not straddling it, but sitting across your view. The conduction will be on the inferior border. As we peer up towards the top of the heart, you can see that remote aorta up there with the infundibular septum there. And this is just to really show you on the model, exactly as in real life. If you look through the tricuspid valve at this anatomy here, holding the septal leaflet of the tricuspid valve, there's the VSD. But because the aorta is so anterior, you can see how difficult it is to view the aorta and see the actual way out in a heart like this. And I think trying to effect a repair of a remote VSD like this through the tricuspid valve is very, very difficult. Although you can see to close the bottom of the VSD, in my mind, it's much better to do this through a right ventriculotomy. Now, we've actually cut away the anterior wall of the RV here to give you a good view of the repair, but you effectively can do this through a small vertical right ventriculotomy, which sits right up there, and it gives you this beautiful view looking down on the inlet VSD, and you can then work out how you're going to carry your pathway with a patch from that remote VSD up to the aorta. So you're trying to imagine the size of your patch. You want your patch to be generous, particularly generous in its width, to create as big a volume outflow tract as you can. So here I've got a little stay suture so that we can move the little papillary muscle around, but we're estimating the length of the patch. And then we need to estimate the width of the patch. And in trying to sort of estimate things, you obviously can't make your patch too big, but as a sort of general guide, I would make the patch 1.5 times the width of that distance between the VSD, the width between the VSD and the tricuspid valve, at least 1.5 times. And then just to show quickly the technique, I would start at the deepest point of the crest of the septum and start off by running around the inferior margin of the VSD. I'm just tucking the patch out of the way. And I have to make a disclosure that really in my practice, I do all of these procedures with interrupted plegited sutures, and I don't use a continuous technique. But I think for the sake of these videos and using these models, it's much more straightforward to show it to you with a continuous technique. But I prefer interrupted plegited sutures. So that's just to remind you where the conduction is in these sort of defects. It's still perimembranous, this defect, although it's very inlet. It's still perimembranous. So we have to make sure that we avoid the inferior margin of the VSD as we come up the inferior border. That's where the conduction risk is. So here we step away from the margin with the sutures as we come up towards the underside of the tricuspid valve. So again, step away from the edge as we come up. And then as we approach the tricuspid valve itself, then the suture actually passes through the hinge point of the valve. So we don't pick up any muscle at all, but just exclusively through the hinge point of the valve. And then you can come back through the valve, back through the patch of the sort of running mattress suture. So if you do this continuous, then you probably want a little ribbon, pledge it, to reinforce the suture on the tricuspid valve side. But here, for the sake of the model, we're just continuing to run it. So here we go, back and forth between the septal leaf of the tricuspid valve. Now we've moved, so we're moving further north. We've come away from the conduction. And so once we've come here, now you can take a deeper bite. So we're no longer just in the annulus of the valve, we've actually picked up muscle. And again, back into the patch. So now we stop and go back to where we started and start coming up the far side. And here you can see us coming up that outflow septum. And I say, Raj, you asked a question, do you need to resect the outflow septum? I don't think you do in a case like this, because it's not in the way, it's not obstructing your view towards the aortic valve. And so resecting it wouldn't really make your pathway necessarily any bigger. So as you come around the top, you can actually suture to the top of your ventriculotomy as you come around. And once you've come around underneath the aortic valve, you come back really to meet that first half of the suture as it comes up from the tricuspid valve. So now we've completed that whole pathway. You've got that large, rather oval shaped patch creating your outflow tract. Again, you can now check for the position of your patch, make sure it's nice and secure. And again, just for the sake of the demonstration, what we've done is just have a look at the pathway, both from above and from the left ventricular side. So we'll show you looking down from above. So here we are, we've kind of transected the aorta to look down the aorta from above. A bit difficult to show you really clearly, but we're trying to show that there's a nice clear pathway through. And if you open up the left ventricle, there we are looking through the VSD from the left ventricle, and hopefully that shows you a reasonably good volume channel leading from the left ventricle out to the aorta. So I hope this is kind of an example of using, even though you've got a remote VSD, you can still create quite an effective, large enough channel from the left ventricle through to the aorta, and therefore affect a biventricular repair. Thank you, Pam. So should let's move on, Pam, to the other video.
Yeah.
Well done. So this is a second of your models that you'll have. And this is really with a sort of, really a sort of doubly committed type of defect. It's a moot point, but whether the VSD is really more subaortic than it is subpulmonary in this example, but you can still see that the pulmonary and the aortic valves are in fibrous continuity. So there is no real, it's a very small conal septum, virtually nothing between the two great vessels. So it's in order to be able to achieve a septation, in order to achieve a biventricular circulation, you've got to commit this VSD through to the aorta and find some way of securing your VSD patch at the top here between the two great vessels, where there isn't really anything to sew to. So again, as before, I think when the aorta is very anterior like this, that it's usually much easier to repair it through a right ventriculotomy than it is trying to work through the tricuspid valve and trying to see up here to a very anterior aorta. Some of these can be done. I'd still prefer to repair these through the tricuspid valve, and it certainly can be done, but it's not always possible. And I think if you find that your view of the aorta it's too anterior, then you're safer doing it through a ventriculotomy. But certainly I think for demonstration, it's much easier for you to see showing here. And I'm just trying to show you at the top there, you can see the pulmonary valve. and the aortic valve are pretty much in fibrous continuity, just with a tiny strand of pink muscle between them. But there's really no infundibular septum there between the two. So you're going to have to commit your patch all the way around there. You've got to work out that long course around the VSD margin and up to the aorta. So once again, it's a question of working out your length and width of patch, and again, making sure your width is really generous to really create a nice large volume to your outflow tract. So same kind of principle again, at least 1.5 times the width, the maximum width of the VSD should be the width of your patch. Again, you know, it's a perimembranous type of defect. So once again, the conduction is going to be running along the inferior border of the VSD, and you want to avoid any risk of damaging that. So once again, starting really at the deepest, the opposite point on the ventricular crest, again, a large or the oval shaped patch. And again, I would start by running inferiorly, coming around the inferior margin of the VSD. You can see we're coming quite quickly to the medial papillary muscle of Lenchisi, which will be your guide for where the bundle will still be very much at risk. Anything you know, more proximal than that. So once you get to the papillary muscle, then we start to step away from the margin of the VSD. So just feeding the suture back and forward underneath the papillary muscle. And again, once we get to the tricuspid valve itself, then the sutures go through the annulus of the tricuspid valve, just picking up valve tissue. And if you can see there, the needle is just coming through the white tissue of the valve. You're not picking up any muscle at all, so you won't risk the conduction. Then back and forward between, there's a sort of running mattress between the septal leaflet of the valve and the patch, until you come really up to the upper extension, and then you can rejoin in a muscular stitch. And we're coming up here as we work up anteriorly around the top to where the aortic valve is, and then we're driving that pathway, and then we then go back to where we started, and we're running up the far side of the septum up towards where there's that doubly committed sort of component of the defect, and coming up under the pulmonary valve. And once you get to the top and there's nothing anymore to sew to, that's when you open up the pulmonary artery. So we're going to open the pulmonary route. And looking down now through the large pulmonary artery, we can see where the patch was coming up from below. And then we can retrieve those two ends of the suture. And now, working through the pulmonary valve, the suture comes up through the patch and up through the pulmonary valve route, or the root of the actual leaflet itself. So the sutures are actually coming up into the pulmonary artery, into the belly there of the cusp of the valve, back and forward. And they both the sutures up in that way, and that way you've sealed off the top of the VSD and you've left the aortic valve behind the patch. I hope that makes sense. And you can do this by working just through the tricuspid valve and the pulmonary valve, or you can do it through a ventriculotomy if you need to. But that's the defect there, sort of committed up through the LV, up through to the aorta. So here again, just looking at the sort of finished product, looking through the ventriculotomy, you can see the patch where it's gone all the way up there around the aortic valve. If we look from above, it's difficult to show, but you can see there the whole pathway through from the aorta down into the left ventricle. You can see the white patch there. It's got plenty of volume to it. So it's not closing down that channel. You made it as big as you possibly can. Well done, Pam. Thank you very much. So I think that's enough. And we will do a demonstration of the Taussig-Bing part as well, but we can do that next week. But any thoughts, any questions or comments before we start to go across to Adriana and Brandon?
So can I ask you one more question?
Yeah.
So I think the terminology and anatomy for DORV with VSD type, top type, and Taussig-Bing type is clearly, but recently the criteria to non-committed VSD is not clear in the literature. So according to your criteria and suggestions, so how to define the non-committed VSD?
So the non-committed VSD, the definition really is where the closest distance between the VSD margin and either of the great vessels, could be either, whichever one's closest, is still greater than the diameter of the aorta. So if that distance is, so if the distance between the VSD and the nearest great artery is greater than the diameter of the aorta, then it's a remote VSD or a non-committed VSD. June, is that reasonable? Would you agree with that? It's quite difficult to give an absolute definition. June, you're muted. Or maybe he's not there. I think that's probably your most kind of practical definition. It's usually fairly obvious. It's pretty clear from the echo imaging and so on that this is clearly non-committed. So yeah, again, I don't want us to get too hung up on the semantics. What we're trying to achieve as surgeons is just find some way of achieving, an effective repair. June, you're there.
Yeah, so I find that I'm muted. Okay, so I think the definition in the surgical literature just clearly, as Dr. Barron said, the diameter it will be aortic valve is a reference diameter. But I criticize that if the pulmonary artery is large and aorta is small, and then you're really overestimating the distance by comparing with aorta. So that's why that I think if it is logical, we need to think about what the normal aortic valve for that age, and then if it is the more than that diameter, the distance, and then it's remote. But it's very arbitrary, and the more important is that whether baffleable or not without obstruction.
Dr. David, can I ask one more question?
Yeah, go ahead.
In your second surgical video, the first picture showed a mildly hypoplastic arch.
True.
The one clip. So how do you address? Yes, how do you address?
So the idea of the model is that you can also actually perform an arch repair on that model as well. But yeah, we were just really showing the VSD closure. But absolutely right. Yeah. Yeah.
Okay, thank you. Because I did one similar case without addressing the arch. The patient came back 6 months later with a coagulation.
Yeah, it can be. Certainly, a lot of these lesions have an association with arch hyperplasia or coarctation.
Okay, so, thank you.
So it's pretty great. Why don't you spend about 10 minutes introducing that ourselves? So to know each other. So it's a pretty special occasion to get together. So again, that my name is Shi-Joon, a cardiac radiologist at the SickKids. So my specialty is that pediatric cardiac imaging. So I have a pretty long career. So in the recent couple of years that I really try to make surgical simulation models. But the reason why I find it is important is that I'm now declaring For instance, node operation. Yeah, the last week, no, the Monday this week, we did the Ross corner operation, and then we had the arterial switch operation. And then seeing those that as a radiologist, seeing how surgeons do, especially in early career, now that as you can see that the motors of the really available with flexible silicone, and then the practice is far more realistic. I really believe now surgeons need to think about doing practice surgery on 5 or 10 motors before even touch the patient. That's my pretty strong recommendation. I think that should happen in the 5-10 years to go. And then worldwide, it should be known. Okay. But anyway, that is my passion. Okay. So let's go around and introducing ourselves. Yeah.
Adriana, do you want to lead the show?
Yes, sure. Thank you. Actually, I was going to ask you, David, if you'd like to go next. Our esteemed speakers and faculty here.
Yeah, well, you've met me. So I'm David Barron. I'm the division head of surgery and sick kids in Toronto, and I obviously benefit, as you can tell, from all of June's expertise.
Thank you. Thank you so much, Dr. Joon and Dr. David. So we have 6 partner sites, CHL partner sites from India and Vietnam who are here today. So why don't we start with Dr. Chuang from National Children's. If you could say your name, your specialty, and your institution, and maybe let's just introduce by institution so that make it a little easier. We're thrilled to have so many participants. So Dr. Chuang, would you like to introduce yourself, and then your team members can introduce themselves as well?
Yes, thank you, Adriana, and thank you, Dr. Barron and Professor Yu. So my name is Dr. Chuang. I'm from Vietnam National Children's Hospital. Every year we perform about 1,000 open heart surgery, almost was complex cases. So today is unique opportunity for us to learn about the 3D printing model from our mentor from SickKids Toronto, Dr. Barron and Dr. Yu. So I believe that our junior staff, including surgeon and cardiologists, they get a great benefit to learn from 3D printing model, and especially with the guidance from 2 worldwide expert in the world, of congenital heart disease. So with your guidance, so I think this is very clear for us to understand the DORV anatomy and how to approach the surgical field for the for DORV repair, and especially for the complex double outlet right ventricle with Taussig-Bing anomaly. So thank you once again. Thank you very much for your support, and I hope our course will be successful, and we hope to see each other in person in the near future. Thank you.
Thank you, Dr. Chuang. We have also another partner site in Vietnam, Nhi Dong Wan, in Ho Chi Minh City, and I believe Dr. Tuan and Dr. Tan are here to represent. Could you introduce yourself? Dr. Tan, perhaps I had to step away. Why don't we continue with India then, our India sites. I will start from the north. We have 2 partner sites from Kolkata. So why don't we start with Aaron Tagore. Dr. Behera, would you like to introduce yourself?
Oh, ma'am, good morning.
Okay. Sorry. Are there other Arctics representatives? Why don't we move to NSH Howrah then, Dr. Debassis and your team?
Morning from here, and it has been a great experience this morning. I'm Debashish. I'm one of the cardiac surgeons here. Dr. Nilanjan here. We are two surgeon team here. All our surgical fellows are here. It has been an absolutely great interaction with Dr. Barron and Dr. Shi-Joon. Even our pediatric intensivist, Dr. Shubhadeep, is here. He spent a significant amount of time in sick kids, so we thought, so he is also attending this, and I'll get Nilanjan to introduce himself. But it's a really great opportunity, and laying our hands on 3D printed models is a great way of learning these complicated lesions. And we hope that our next hands-on session will be even more interesting. Thank you for this great opportunity. I'll hand over to Nilanjan and then Shubhadeep.
Yeah. Thank you very much. Again, I'm Dr. Nilanjan from the same hospital. It was again a fantastic the experience looking through the models about the intricacies of the DORV. The DORV is definitely one of the congenital heart disease which can come with a lot of variables. So it was really fascinating. Thank you very much, actually.
Shubhadeep, you want to say something?
No, it's really a wonderful experience. When I was there in sick kids, Shi-Joon was developing all these models, and now seeing them in real time. So it's a wonderful experience. Thank you.
Thank you so much, Dr. Debashish and team. Let's move to PGI Chandigarh. Dr. David and Dr. Mishra, would you like to introduce yourselves?
You are muted.
Yeah, very good morning. I am Dr. Anand Mishra, professor in CTVS, surgeon, and my colleague Dr. Javed is here. He's again joined us, and we are really thankful to all of you for a very nice lecture. And I will especially thank Ms. Andriana for your cooperation to have this lecture with us. Thank you, ma'am.
It was really a nice experience, sir, seeing all those heart models. It was really new to us, especially with all the 3D printed models. We could understand the anatomy in a far better way compared to just studying the books and videos. Thank you very much, sir.
Thank you so much. Vijay from GKNMH in Coimbatore, please introduce yourself.
I'm Dr. Vijay Kumar Raju. I'm a pediatric cardiac surgeon working on G. Kuppuswamy Naidu Hospital in down south of India. Actually, I enjoyed both the lectures. I mean, as I'm sure all of the participants really want to express their gratitude and thankfulness to both Dr. Shi and Dr. David Barron. It's really a nice experience. But Adriana, a small request to you, maybe in the future, I mean, you know, we can come up with some complex topic like this and get the experts to speak to us, something we should consider, because
sure.
As the pandemic opened up the Zoom and in a virtual forum, I think this is a better way of learning things. You know, small tips here and there will make us fine tune our things, and the results will get better eventually. And can I ask one question to Dr. Shi-Joon? Is it okay, Adriana?
Please go ahead.
Right. Dr. Shi-Joon, one of my young radiologists, he does not have a cardiac background. He wanted to learn cardiac imaging. So but he's very nervous considering the complexity of cardiac anatomy. What will you advise? But he's kind of interested to it, but he's finding
actually we have the cardiac imaging fellowship in the last 20 years, actually 21 years. So we have honestly, we have trained more cardiac imagers for MRI and CT, the MRI mostly, than any other institution in the world, including Boston. So we have the really very robust training program, and then we are very successful in satisfying our trainees. So if you're the junior step or any trainee would be interested in taking training, so the about 2 years in advance to contact us, and then the position is there for competition. Yes.
So you can yes.
No, I was just going to ask Dr. Joon if you have any virtual, now with the great strides that Sick Kids has made to offer virtual content. I was just wondering if there was any virtual content or trainings, courses that perhaps potential, those interested might be able to attend.
Yeah. But however, virtual is good, but the program for MRI is really hands-on experience in scanning and seeing the patients. And then the strength of our program is that all trainees have opportunity to do all the scanning and the post-processing themselves. The PEM Septum 1, they got the training last year, and then I think she's very satisfied with. And then most of the time we find that our trainees are very happy, and I'm very proud of our training program too. Yes.
Thank you.
So how long is the duration of the training fellowship?
So the regular training is 1 year, and then even if for the experienced people, we advise that at least 3 months, and then just a little bit of experience, minimum 6 months. But 1 year is regular. 3 months and 6 months is a kind of not really necessarily having hands-on experience opportunity, because we need to go for the license.
Sure. Do they have to have any exam cleared prior to applying for the position, Dr. Shi-Joon?
Yeah, we have here the website. Yes, you can email me that I can send you.
Yeah, thank you, Dr. Shi.
Thank you.
Thank you, Adriana, for making it happen.
Thank you. Thank you for making those connections. Yeah, thank you so much. And then last but certainly not the least, our Center of Excellence, Amrita Institute of Medical Sciences in Cochin. Dr. Brijesh and team, would you like to introduce yourselves?
Hi, it was a really wonderful experience to hear in detail regarding the DORV, various types, and the surgical techniques. Great experience to have both Dr. Shi-Joon and Dr. Barron. We are Amrita Institute of Medical Science, Kochi. It's from the south of India. We are 3 surgeons over here. I am Dr. Brijesh. My colleagues are Dr. Praveen Reddy and Dr. Balaji. So we are the 3 teams, and we have been using 3D printing and technology. Thanks to Dr. Mahesh, who is the pioneer here in pediatric cardiology, who's been using 3D printing and technology. And we have been using that for the treatment of DORV and surgical treatment of complex DORV lesions. So it was a great experience to be here and to hear from the experts about the various nuances of surgery and how we think about treating DORV. And I would like to Dr. Mahesh to speak. He's with us and he's been patiently hearing the lectures. Dr. Mahesh.
Hi, very special.
Hey,
Hi.
How are you?
Very well, very good. So I would just like to say that Dr. Shi-Joon has been personally my inspiration and remotely my guru over the last decade or so. And seeing him and following his footsteps, we created our own 3D lab here in Amrita way back in about 2015-16. And I think that Dr. Shi-Joon has one of the deepest insights into cardiac morphology of any person on the planet right now. And the concepts that he elucidates really helps us understand this morphology so much better. So we've been using 3D printing, both physical 3D printing as well as virtual reality at our hospital very regularly to help our surgical team plan the repair of complex DORVs and other complex lesions. And definitely it really adds value because we go in much better prepared with much better understanding. Thank you so much, Dr. Shi-Joon, not only for just being part of this session, but for leading this whole revolution in understanding morphology through 3D plus technologies. And thank you, Adriana, Children's Heartland, Dr. Barrow, for the wonderful session, which I'm sure has helped everybody.
I didn't realize that you are sitting behind, and then really, the coaching that congratulations that I was a visiting professor a long time ago, and then you studied 3D printing, and then you were the major speaker in the major conference in North America, and the really a big progress you made, and congratulations.
Thank you so much, Dr.
Thank you. This is always my favorite part of our this kind of trainings, is making those connections. But this training is truly special. Dr. Joon and Dr. David, really can't thank you enough. But I also want to give a special thanks to Brandon, who has truly made this all possible. Without you, Brandon, these models would not be with our participants. So thank you for connecting them. And Dr. Pam, too, for recording those wonderful videos. Thanks so much.
Yeah, Pam and Brandon, show yourself.
And just one more thing, if there are more ways in which sick kids and maybe our 3D lab, Dr. Joon, if there are ways of connecting more regularly in the future and working towards developing these technologies further, especially in the limited resource environments. So we would be very happy to participate in anything at all of that nature.
Yeah. So here that Brandon, why don't you introduce yourself and Pam too?
I'm Brandon. I help manage the host program. I've done this for almost 4 years come the fall. I'm always excited to see everyone, all the new faces each time. As time progresses, we get more and more host courses, and as you can see, the increase of the fidelity of the models is always increasing. So it's always nice to see that, and just having all the surgeons participate, it's great to see.
Thank you.
Hi, I'm Pam, pediatric cardiologist. As a background, I'm not a surgeon, of course, but then I really enjoy this course as well. And while I'm doing all the video, I learn a lot. I would like to thank you, Dr. for this great opportunity that that allow me to attend in the 3D printing fellows and be a part of this whole course.
Pam surprises me every day. For instance, today, I didn't expect that the two video, the clips already edited and be shown. I can't believe that you really energy and capacity to do it. Thank you very much, Pam.
Yeah, you're welcome.
Thank you. I think these are all of our participants. Brandon, would you like to take it away for the last piece of our discussion about the next training and how to use Zoom for the practice piece? Oh, yeah. I'm sorry. I have here, there's a message. I'm sorry, Brandon, just 1 second. Dr. Let's see, Dr. Vin from NCH asks if he could say something. Dr. Vin?
Yeah, hello. Yes, hello. Good morning, Professor and colleagues. And first of all, thank you, Children Hotling and Dr.Shi to organize this amazing workshop. And I have a chance to meet Professor David, Barron, and Adriana in person. And I think this is an excellent workshop, and I have joined the TOF repair previously. And 3D models, I think, is a solution to resolve the problems of surgeon, how to be ready to the surgery. Because as I completely agree with Dr. Zhu that we have to practice in at least 5 models before touching the patient, right? But I think simulation in surgical field is quite a problem, especially for complex surgery like congenital heart defect repair. And as in Vietnam, this 3D printing model is really amazing tools for baby surgeon like me to understand the morphology and also to practice my skills. So I really hope, I wish that we as baby surgeon could join more workshops like this in the future, and also that children hardling or total circuit will support us like a way of approach these models regularly in the future for our next generation of surgeons, right? So yeah, from my bottom of my heart, I'm really thankful for that, and thank you. Wish you all good health in the times difficult time of COVID-19. Thank you.
Thank you.
Thank you. Thank you so much. Brandon, would you like to take it away for the some tips, I think, on how to successfully Zoom and simulate the operations for the next session?
Yeah. Thank you, Adriana. So I think there are 3 packages that are yet to be delivered. I think between myself and Adriana, we're talking to FedEx almost every day trying to get those released. So we're pretty sure that they're going to be delivered in time. For those who have the models, either the surgical light edition or the actual chest simulator, there are ways to set up properly. You should have received a little brochure to show you exactly how to set it up. But if you have any questions about quality audio or general setup, feel free to reach out to me. I'll be available tonight or in the beginning of next week. So I'll log on early if you guys want to just test quality video or just general setup, or just have any general questions, I'll be there to answer. But we'll all do it through Zoom, so all the controls will be on Zoom itself. Does everyone have any questions for me as of right now?
Do you have any questions about the models and what you have received or how to set it up? You can feel free to ask right now, or connect with Brandon later on. Sounds good. Okay. All right. I have to say the models, I'm very impressed, just kind of blown away, even as a non-clinician, seeing the models that were in the video. Those are the silicone models, aren't they, Dr. Joon?
Yeah.
Impressive.
So basically, it is not 3D printed one. We designed with the 3D molding, and then we tested that with the 3D printing. And there is another process, a molding process, to generate it, because the currently 3D printer is not good for silicone. So that's why that it is all molding technique.
Wonderful. Thank you so much for pioneering these new techniques and for us to be able to be the beneficiaries of this advancement and innovation. Thank you. Do you have any other questions or concerns or things that we should discuss, Dr. Joon and Dr. Barron, before we conclude the session?
No, I think that's great. It's been great fun. Thank you, and great to see you all on the call. So I think we'll see you all next week. But again, as Brandon says, if you have any sort of practical questions about the models and how to set things up, then just get hold of us through Brandon or the host email, and or either me or June, and we want to get things all running smoothly next week.
Thank you again, Dr. David. Thank you for your.
Thank you.
Thank you.
Thank you.
Thank you. Take care. See you next week.
See you again. Thank you.
Wonderful.
See you next week. Thank you.
Take care.
Thank you.